Hi guys, welcome to Snapshots. I shall now be discussing cardiology image-based questions with you, and most of them are based on your ECG interpretation. Let's get started with the very first one. This talks about a patient who was collapsed while waiting for boarding an aircraft and was rushed to the medical room. Which is correct regarding the ECG? The moment whenever a ECG is given to you, your response should be you should be able to analyze the heart rate and similarly pick up any gross changes because person has collapsed. It could be a cardiac event, something like a myocardial infarction or a tachyarrhythmia. And while I'm just looking at the ECG, I definitely can notice that the heart rate of this patient is usually about 100 or so, because 3 large squares can definitely be picked up. So the heart rate of this person would be 300 divided by 3. It's a little more than 3 actually, but just for calculation purposes, I can say that mathematically the value will turn out to be less than 100 per minute. What you can see is a very characteristic ST segment elevation which is present in lead number 2. It is found also in lead number 3 and also in lead number AVF, and there is a reciprocal, we'll use a different color to highlight, a reciprocal ST segment depression present in lead number AVL. And I've highlighted a couple of times that whenever you're going to be getting ST elevation in 2, 3 and AVF, it means that the inferior surface of the heart, that's the right ventricle, is going to be infarcted. Therefore, the diagnosis of this patient will definitely turn out to be an inferior wall MI. Now, the point is there are two options present, inferior wall MI and inferior posterior MI. So, I need to be a little careful before I comment on the diagnosis. Obviously, I can straight away rule out it is not an anterior wall MI because anterior wall MI will be mainly having findings in V1 to V6. Now, look at what is happening in V1 to V6 in this patient. That's the main crux of this discussion, guys. There's a definitive ST segment depression present in V1 to V2, which is normally not present in a case of inferior wall MI. Inferior wall MI should be having a ST elevation or ST depression in 2, 3 AVF, right? It should not be having ST depression in lead number V1, V2. Whenever you are having a ST depression in V1 to V4, you should always think in terms of possibility of posterior wall MI. Obviously, when you are having a posterior wall MI, you also need to put special leads. No, that is going to be V7, V8 and V9 as I've told you in the main lecture, but the catch in the question is your observation. So see, if you're going to casually look at it, this is going to be answered as inferior wall MI, which is going to be wrong, because in inferior wall MI you're not going to have these findings which I've highlighted here. Guys, when you have V1 to V4 here, it is only V1, V2. That means I would say some part of the posterior wall is hampered. But whenever you read about this, and I've highlighted this when I have taught you regarding ECG interpretation, that whenever there's a V1 to V4 having ST depression, always keep a watch for the blockage of the posterior descending artery. This patient is actually having an inferior posterior myocardial infarction. The answer to this question is option number A. I want to reiterate the fact that before you look at whatever is the obvious answer in the question, just be looking at some additional findings that may be given. In this question per se, just to introduce error on the part of judgment that this question was introduced. Otherwise, I could have given you a simple one of plain inferior wall MI as well, but that would not have shown this specific finding. So answer to this question turns out to be option number alpha. Anyway, whenever you read about a person collapsing suddenly, either it's going to be question of a tachyarrhythmia like ventricular tachycardia or ventricular fibrillation or maybe a PSBT. These are the usual 3 arrhythmias that are asked. So when I looked at this ECG, I tried to be fast here because you see, if I go by the routine steps in the ECG, there's a possibility that I might keep on analyzing it only and I am losing valuable time. So the point is, when you read about a crashing patient, you have to think in terms of a tachyarrhythmia, you have to think in terms of a cardiac event like a coronary artery getting blocked and a MI developing in a patient, which was very much obvious in this case. The answer is A, as explained to you because of the findings highlighted in red. We move to the second question. This is about a 65-year-old diabetic who's presenting with excessive sweating and dizziness. Now, please remember that diabetics can even be having a silent myocardial infarction. So, if a diabetic is having a lot of sweating, dizziness, it could be possibility of the fact that either he's having hypoglycemia or he's having a myocardial infarction. So before you comment that there is a hypoglycemia, you must also evaluate the ECG of the person. And anyway, I'm ruling out hypoglycemia here because no blood sugar values given in this person. Had I just used a capillary blood glucose value also, that would have been sufficient. If it was requiring management of hypoglycemia, I would have given 10 to 25% dextrose. Whatever is available, ideally would be 25 to 50%. If not, even I can give 10% dextrose. But this chap is definitely showing some very dramatic findings. The dramatic findings are, if you look at the heart rate, it will be approximately 100 per minute. That would be 300 divided by 3. Now we will calculate the axis. In Access, you have to look at the data of lead number 1 as well as lead number AVF. If you look at the data of lead number 1 per se, it's going to be mainly positive, R minus S, I'm going to plot it. And when it comes to lead number AVF, again, if you look at the data here, you can see that R and S are almost of the equal size. So I'll give benefit of doubt and give it as positive. So the axis of the patient is anyway turning out to be normal. However, as you move laterally towards the lead number V1, V2 and V3 and even going up to V5, there is a very substantial ST segment elevation present in the patient. You can notice this very peculiar ST elevation, and well, this is called as tombstone pattern. No? Tombstone pattern mainly to highlight that this person is unfortunately not gonna make it and he may go to God. Tombstone pattern is again a feature of ST elevation, which is encountered in myocardial infarction. And since this is involving V1 to V5, though ideally it should be up to V6 also, but luckily some part of V6 might have been spared. The diagnosis of this person is extensive anterior wall myocardial infarction, and the blood vessel that is blocked in this patient will be left main coronary artery. I'm writing LMCA, means left main coronary artery is the one that is compromised in this case. And sometimes, I mean, this guy is lucky he reached the hospital. A lot of these patients may never reach the hospital, especially with the extensive anterior wall MI, because of the damage and the associated tachyarrhythmia, ventricular fibrillation will occur. So this person can expire pretty fast. When it comes to ST elevation, though this has been explained to you in the routine lectures, I want to emphasize once again, you can be having ST elevation that can be convex upwards, it could be concave upwards, or it could be having this configuration that is shown in lead number V1, which is called as a cove pattern with a T-wave inversion. In fact, sometimes there's also possibility that there might be a saddleback also present. If you look at the first sketch, I have shown a ST elevation which is convex in upward direction. That's a feature of myocardial infarction. If you look at the second one, I've shown a ST elevation which is relatively concave upwards. That would be a feature of acute pericarditis. You can obviously differentiate between MI and pericarditis by biomarkers, but he'll definitely give you the ECG because he doesn't want to make it easy for you. The inferior two that I've highlighted, the first one is called as cove pattern, COVE. This is also called as Brugada pattern per se. And the second one is called as saddleback. You can notice the notch in between, right? This is when the T wave is starting. Both of these are going to be seen with respect to a sodium channel defect in the heart that can cause sudden cardiac death. Has been discussed, SCN5A defect, Brugada syndrome. And these are the various types of ST elevation that you should be familiar with. The next question is relatively longish. He talks about a 70-year-old man with recurrent episodes of arrhythmia shown below after he recovered from a STEMI episode in March 2020. So he is telling you that he had a ST elevation MI. He has recovered from that, but after recovery, he is having these recurrent episodes of this tachyarrhythmia. You can very well notice a very, I would say, identifiable broad QRS complex tachycardia. The heart rate of this patient will be approximately about 150 per minute. If you look at the distance between the R and the R waves, this would be about 1.5 large squares. Heart rate is calculated by 300 divided by the number of large squares present between R and R, which in this case is 1.5. LS means large square. So this will work out to something in the range of, I would say, about 200. So something in the range of 150 to 200 is the heart rate of this patient, which is substantially fast. And then he's telling you that he was put on aspirin, clopidogrel, rosuvastatin, metoprolol, ramipril. They are standard treatments that are given post-MI. And he had to be given DC shock for treating these recurrent episodes of arrhythmia. So what could be the etiology behind the recurrence? Option number A says Brugada syndrome. See, patients of Brugada syndrome will not have a myocardial infarction. No, Brugada will cause sudden cardiac death. I'm ruling out option number A because one, it will occur in young people. The history in this young man will be that either he suffers from recurrent episodes of palpitations or pre-syncope or syncopal episodes, and his elder brother had died suddenly. So Brugada syndrome is going to be disease encountered in young population. It's not going to be 70-year-old man who's already had a cardiac event. I mean, it does not make sense to make two diagnoses in a single guy. No? If a patient is having a presentation, it's going to be a single diagnosis only. So I've ruled out Brugada. LV aneurysm. LV aneurysm is one of the post-MI complication, and that can be due to the extensive damage that has occurred to the myocardium, that there is necrosis of substantial muscle, so the heart wall will bulge out. When I talk about LV aneurysm, because it's a structural damage in the left ventricle, the structural damage can cause two problems. One, it can cause clot formation inside because the damaged part will be having less contractility, so there would be stasis of blood. This will cause clots to go into systemic circulation, so that would be one of the reasons. And the second reason what I can say is that because there's a structural damage, there can be a short circuit, because normally the myocardium, endocardium, they definitely should be having a proper sync with respect to RMP. If you are having a structural damage, then the resting memory potential changes dramatically because of the ischemic damage, and this can contribute to a short circuit and tachyarrhythmias. So this looks like a plausible answer. C says wrong combination of drugs given. So let me read the drugs again. Low dose aspirin, clopidogrel, dual antiplatelet therapy, rosuvastatin, metoprolol, ramipril. See, he is already recovered from a STEMI episode, so giving him dual antiplatelet therapy is the right thing to do. It is unlikely that C would be responsible or medications are contributing to these recurrent dizziness episode, because even if he was giving, let me say, nitroglycerin or NTG, in this particular question, I could have thought the nitroglycerin overdosage could contribute to hypotension, and thereby this person could be having some issues. So C and A can straight away be ruled out. You are left between B and D. Now let's look at Ashman phenomenon. Well, Ashman phenomenon is seen in atrial fibrillation. One, remember, Ashman phenomenon is associated with atrial fibrillation. Atrial fibrillation has a narrow complex tachycardia. Well, what is Ashman phenomenon? It can be a right bundle branch morphology that could be found in a ECG of atrial fibrillation. Now, even if you don't make life difficult for yourself, the basic point is Ashman phenomenon per se is something that you are not read with myocardial infarction. What you read with myocardial infarction is the standard information, a late complication that can develop LV aneurysm. The structural damage which is present here can actually trigger recurrent ventricular tachycardia. This guy is a perfect candidate for implantable cardioverter defibrillator. I mean, if this patient came to me and I have treated him with the cardioversion, I would be telling this person before a discharge that I would suggest you to get admitted. We would be doing a cardiac mapping. We'll do a mapping of a heart, that is electrophysiological studies, because non-medicals don't understand electrophysiological. So I'll tell him we'll do heart mapping to evaluate how the electronic short circuit in your heart is occurring, and then subsequently we can deploy a implantable cardioverter defibrillator that will terminate the arrhythmia without you having to even be aware of what is going on. I mean, you will feel some palpitations. The moment the arrhythmia will start, the computer will sense it and will terminate the arrhythmia directly. The answer to this question is option number beta. LV aneurysm is a complication. It's a structural complication of myocardial infarction. It's a complication due to necrosis, but it's a relatively late complication. And because there's a dilatation in the wall of the heart, so it can contribute to two problems, as I explained. Either it can cause embolic stroke, because there would be stasis and there would be clot formation, or for that matter of fact, it will act like a nidus for short circuit. That would be tachyarrhythmias developing in the patient. Coming to the next question, he's talking about a COPD patient presenting with palpitations and pre-syncope, and admission blood pressure is on the higher side, and he's having a loud S1 and a normal split second heart sound. Well, what's the information provided? One, it's a COPD patient with a tachyarrhythmia. You see why? Because I'm saying palpitation. So let me just evaluate the ECG of this person and I'll evaluate the heart rate. Now, when I evaluate the heart rate of this guy, something very interesting in coming up here, which is that when you look at the RR interval, there would be 3 large squares. That means the heart rate would be about 100 per minute. But if you scroll a little laterally, you will notice that there is only 2 large squares present. This means that the heart rate of this patient is now 150. So in a single ECG, you are noticing 2 different heart rates in the same patient. This is basically an irregular RR interval. The first and the foremost thing that you have to understand from this MCQ is there is evidence of irregular RR interval, and irregular RR interval has been taught to you 2 times only. Irregular RR interval is found in atrial fibrillation and multifocal atrial tachycardia, and which is more common in COPD, multifocal atrial tachycardia. Let's look at another difference. If it is atrial fibrillation, you will never be able to see the P wave. Here you definitely can see the P waves present. I'm ruling out atrial fibrillation in this chap right away because I can definitely see P waves, and each of these P waves, look at the configuration. I'll just erase it a bit. Look at the height of the P wave with respect to each one of these guys. You will notice, in fact, I'll use different colors so that it becomes more obvious for you. Look at the height of the P wave. and compare this with the subsequent one, or maybe the one which is present in intervening area, you will notice that there are three different morphologies of the P wave. This is a classical case of multifocal atrial tachycardia, and anyway, whenever he gives you a scenario of a COPD patient having a tachyarrhythmia, whenever he gives you a scenario of a COPD patient having a tachyarrhythmia, multifocal atrial tachycardia should always be on the radar. The correct answer for this question will turn out to be option number C. Atrial flutter is ruled out because there is no sawtooth pattern that is visualized here. Atrial fibrillation is ruled out because it should be having absence of P wave, whereas here P waves are present. And paroxysmal supraventricular tachycardia has a very characteristic morphology, which I can hand draw before you once again. A global ST segment depression. Then there would be absent P waves again because there is merging of the P and the T wave, and PSVT ECG will anyway come up subsequently. I mean, it is always a must know for you to go through these rhythms, especially with respect to multifocal atrial tachycardia, atrial fibrillation, ventricular tachycardia, and the PSVT, because these are the common arrhythmias which have been asked upteenth number of times, and I usually find people skipping these topics, whereas it's always a good idea to invest, especially I would say in cardiology, which is must know for you is ECG and arrhythmias part. I mean, those two lectures, if you go through at least 2 or 3 times, then in your subconscious you will have an imprint regarding what is the arrhythmia present, and you will be able to pick up these minor points in the question by which you will be able to identify which kind of arrhythmia is present, and then definitely the treatment part of this can also be asked. The answer to this question is option number C. The highlight was irregular RR interval. So the word of caution here is, whenever you are attempting any multiple choice question, always in ECG calculate the RR interval minimum 2 times instead of doing it only once, because you might miss the irregular RR interval, and atrial fibrillation and MAT will therefore be, I mean, if they're asked, you might miss out on them. Coming to the next question, he talks about a patient who's become pulseless and his BP is crashing after myocardial infarction. What is the diagnosis? First and foremost, you will notice that this is a broad QRS complex tachycardia, and the height of these QRS complexes is also almost the same. So because the height is still the same, you will add the prefix monomorphic. If this height was varying, I would have said polymorphic ventricular tachycardia, that is torsitis de pointis. Here, I'll just show the symmetrical pattern which is coming up here. The height is almost identical, and you can definitely notice a shelf, or I would say a notch, which is present in the downswing of the S wave. Anything that goes up is R, anything that comes down is S. In fact, I'll use a finer pen and zoom it in so that you can be more sensitized to this shelf or notch that I was talking about. This is very characteristic of ventricular tachycardia, extensively asked in the exam. This is called as Josephson sign and helps you identify a VT. This is a monomorphic VT, guys, and if it is pulseless patient, then we will go in for a DC shock, and that would be a non-synchronized DC shock. The correct answer for this question is option number alpha. Bidirectional tachycardia is always seen with digoxin. So you will always be having rather a pediatric patient, because lots of time we use digoxin in heart failure for pediatric cases. So bidirectional tachycardia is very characteristic that you read in digoxin toxicity. Polymorphic ventricular tachycardia, how am I ruling it out, is because the amplitude of the broad QRS, I repeat the fact once again, the amplitude of broad QRS is equal in each of these leads, irrespective of wherever you look at. But when it comes to amplitude of broad QRS being unequal, that's a feature of polymorphic ventricular tachycardia, which is treated with magnesium sulfate or a DC shock if required. And ventricular fibrillation is a piece of cake for you. I mean, you can rule it out immediately. That would be just having this twitching and dancing around the baseline. It will not have this well-established waveform. The heart rate of this patient is approximately 300 divided by 1.5, give and take a few squares. So I would say that approximately 200, something in the range of about 180 to 200 will be the heart rate of this guy, which is disproportionately fast. I mean, the heart will beat very, very fast. It will not have time to relax. If it will not get relaxed, less will come in, less will be going out. That is explaining why the BP is falling, because normally what happens is that whenever heart will beat fast, BP should rise. But here, because the relaxation component is affected, therefore less comes in, less goes out, and that is why the blood pressure is given to be lower in this case. Or rather, I would say that this patient is having a pulseless ventricular tachycardia of the monomorphic variety, and we need to give a DC shock for this individual. The next question talks about this 25-year-old lady who presents with recurrent episodes of syncope and palpitations, and the ECG is showing a very characteristic sawtooth wave pattern. You can notice that before every QRS complex, There is the sawtooth pattern which is present. This is revealing a presence of 3:1 conduction. Though you can see only two sawtooth waves present before every QRS complex, this is not 2:1 conduction, this is 3:1 conduction. The basic rule to be remembered is, suppose you are seeing one wave before every QRS complex, it means one wave is not conducted, one wave is conducted down into the bundle of waves. So you call it 2:1 if it is one. Here, because it is two abnormal waves, so you will call it a 3:1 conduction. Again, very frequently asked in the exam. The correct answer for this sawtooth pattern is atrial flutter. Now, if they give you the complete ECG, that is a routine 12-lead ECG, where are you going to look for this sort of pattern? Then it's going to be looked at in lead number 2, 3 and AVF. And why that is so is because the macro reentrant circuit, if you go through the literature of atrial flutter, I have highlighted that there is a macro reentrant circuit in the right atria, and right atria can be, or right side of the heart can be evaluated using the following leads. So, I mean, the remaining leads may or may not be showing this abnormal waves, but yes, lead 2, 3 AVF will always be spot on to pick up a atrial flutter for you. And if he says right control, it would be esmolol / verapamil. If he says rhythm control, we can be using ibutilide, and that has been discussed in the main section of the app, where ECG and arrhythmias, as I've highlighted, is always a must know for you. I mean, those two lectures are gonna be having zero error possibility for you. In fact, I mean, you cannot afford to go wrong in ECG because your rivals will be scoring there. So if you spend some time on analyzing these rhythms, then you will be more comfortable, and you will see that your strike rate in even other topics will increase. The next question talks about a child of valvular heart disease on a heart failure treatment with the ECG tracing given. Now, first and the foremost thing is, if a kid is on heart failure, what are the drugs that are used? So one of them that is used in pediatric congestive heart failure is digoxin, and the second one that is used is diuretics. And I'm aware that diuretics cause hypokalemia. So my thought process is this ECG showing evidence of hypokalemia? I've explained to you that hypokalemia per se would be having decrease in the height of the T wave. It would be having an increase in the height of the P wave. There would be a pseudo P pulmonale present. Whereas second possibility in the question can be, it can talk about digoxin toxicity and the arrhythmias associated. If you look at option number A, tall tented T wave, that's a feature of hyperkalemia. It is unlikely to be the answer to this particular question. Why? Because if somebody is on diuretics, it will cause hypokalemia. So I'm ruling out option A. The remaining two, ventricular bigeminy and non-paroxysmal atrial tachycardia with AV block, option number B and C, are features of digoxin toxicity. So I need to select between them from the rhythm. You see, when it comes to option number D, that's anyway dummy choice, because I know the fact that even when you study the topic of digoxin toxicity in pharmacology, they always talk about the commonest arrhythmia of digoxin toxicity being ventricular bigeminy. And the characteristic arrhythmia of digoxin toxicity as NPAT, non-paroxysmal atrial tachycardia with a variable AV block. So I need to select between B and C only. And now let's look at the ECG of this person. I'll just zoom it for your convenience. You will notice very characteristic P wave present, then a QRS complex with a slight T wave inversion. After which you are noticing presence of a really broad QRS complex, this that I've highlighted before you, which I can call as rather a QR complex as well, is a premature ventricular contraction. The ventricle is getting depolarized early and then is contracting also early, though it will be an ineffective contraction. Then again there is a normal sinus rhythm with a mild T wave inversion that could be coming because of digoxin, but then there's again a very deep Q followed by R. You see, everything that goes down before the R wave is going to be a Q wave only. This is a premature ventricular contraction. There's a big septal activation happening and then there's a ventricular contraction. So what you are noticing in the ECG of this patient is an alternative normal sinus rhythm PVC, and this is technically called as ventricular bigeminy. The correct answer to this question is option number beta. Coming to the next question, he's talking about a 75-year-old person who comes to a ESI dispensary and is complaining of exercise intolerance. In cardiology, if the age of the patient is going to be usually in geriatric age group, usually there are two possibilities. Either it's going to be a question on acute coronary syndrome event, or it's going to be a valvular aortic stenosis. The question then says, on auscultation, a systolic murmur grade 3 is heard. So I think that the question is based on valvular lesion only. But let's look at the ECG of this patient. And the moment you scan through the ECG, the first thing that strikes you is very significantly tall R waves present in especially lead number V4, which are in fact going out of the routine tracing. So my first thought process, considering the age of the patient, systolic murmur grade 3, I am thinking in terms of valvular aortic stenosis. Well, aortic stenosis is not in the options, but you can see one of the complications of aortic stenosis is very much in the options. That's going to be left ventricular hypertrophy. Now, obviously, this ECG is not normal, so we can rule it out. When it comes to the diagnostic criteria of left ventricular hypertrophy, we call that as SV1, that is the depth of S wave in lead number V1 and the height of the R wave in V5, V6. If we add this, if it is more than 35 millimeter, we should definitely think in terms of LVH and send the person for an echocardiography. So let's do this activity of counting the number of the large squares with respect to lead number V1, and you can see a huge, almost I would say a little more than 5, or even if I extrapolate to 5 large squares, that will make a 25 millimeter here only. Now when I scroll laterally, you can see in lead number V5, you can count 1, 2, 3, 4 and a little more than that. So even if I am moderate in my considerations, 20 millimeter is what I am thinking for V5, and 25, if you add the two, this makes up a huge hopping 45 millimeter, and the cutoff that I taught you was 35, that is required for diagnosis. So left ventricular hypertrophy looks like the most probable answer to this question. Option C says atrial fibrillation. Well, it should always be having absence of P wave. So I zoom into the ECG once again. You definitely can notice very characteristic P wave with the normal duration and height present before every QRS complex, and as such there is no irregular RR waves also or irregular RR interval. So atrial fibrillation definitely is a very unlikely answer to this question. Left bundle branch block. Well, the important feature that we use for diagnosis of left bundle branch block is called as William. What you mean by the word William is that in lead number V1, you will be having a deep and a broad S wave. In this case, there is definitely a deep S wave, but not a broad S wave. And most of the time in this broad, deep S wave, there might be this W pattern. This W pattern basically, or we can call it M pattern sometimes, or inverted M. This actually highlights the sequential activation of ventricles. You see, in you and me, there is always a simultaneous activation of ventricles, but in these patients, there will be a sequential activation. So because we cannot see any characteristic M pattern, because in lead number V6 in left bundle branch block, there should definitely be a broad dominant R wave with this M pattern coming up, again representing the sequential activation of ventricles and intermyocyte conduction, not visible in this case. So by exclusion also, the question can definitely be solved. And what I would like to highlight is that even if you are not interpreting the ECG, even if you don't know the ECG criteria for LVH, this question can still be solved only on the basis of theory. The parameters are age of the patient, symptoms of the patient, exercise intolerance, and then valvular obstruction will definitely contribute to a systolic murmur, and the intensity of the murmur will rise and then will decrease. So we call it a ejection systolic murmur. Moving to the next one. This is about a 65-year-old man who's coming to you with crushing chest pain for last 2 hours. On examination, BP is dramatically low. So that's a cause of concern. Either it could be anterior wall MI, it could be inferior wall MI, because anytime if the ventricles will fail, either one of the two, the blood pressure should crash. JVP is elevated 4 centimeter above the sternal angle. So that is telling me probably right ventricle is the one that is at fault. Though obviously left ventricular failure causes right ventricular failure. So I'll keep my options open. All are true about the condition shown except. So what I have interpreted from the theory per se is this question is based on acute coronary syndrome, most probably can be an MI because the blood pressure is dramatically low, and JVP elevated tells me that okay, right side is getting involved either due to isolated right ventricular involvement or secondary to left ventricular involvement. So I scroll through the ECG and you can notice very characteristic ST segment elevation which is encountered in lead number 2. You can notice the same in lead number 3 as well. You can notice the same in lead number AVF as well. So, well, whatever interpreted from the ECG would be a inferior wall myocardial infarction in the patient. Along with this, I can also notice some reciprocal changes, especially in lead number AVL. You can notice some reciprocal ST segment depression present. I would like to call this ST depression as reciprocal changes, and that always happens in inferior wall MI. That if you want to be sure, just look at 2-3 AVF and then look at the reciprocal changes in lead number AVL. The question says all are true about this condition shown except. The point is in inferior wall MI, you will always be having hypotension. Why? Because the right ventricle is on a malfunction. If less blood will go to lungs, less will come to left side, so the BP will dramatically fall. So I want to maintain the perfusion to vital organs. So will IV fluids be given? You cannot ever give IV fluids in anterior wall MI, because in anterior wall MI there is a pulmonary edema. But in inferior wall MI, right ventricle will fail, blood will not go in the lungs, so there will be no pulmonary edema. So IV fluids can be given in inferior wall MI. In fact, you never ever give fluids in any type of MI except inferior wall MI. So IV fluids will definitely help you to maintain the baseline perfusion of vital organs. ST segment in elevation in lead 2, 3 and AVF, yes, I just demonstrated that. Inferior wall MI mainly signifies right ventricular damage, but look at what he has written. Give buccal spray of GTN. Now, if you're going to give nitrates to a person whose BP is already low, the point is, if somebody's BP is already low and you will give nitrates because it is a vasodilator, it will rather cause worsening of the hypotension of the patient. I have highlighted this even in the routine lectures that we do not give nitrates to patients of inferior wall MI. Nitrates are contraindicated, especially if systolic blood pressure is less than 90 millimeters of mercury. Even if you cannot interpret this ECG, the basic point that you need to understand is dramatically low blood pressure values of this person, and since the BP values in the patient are dramatically low, GTN will definitely not be done, or GTN will not be administered. The answer to this question is option number delta. Coming to the next question, it talks about a 16-year-old boy who is having history of recurrent episodes of fainting in the school assembly, and the ECG of the patient was done. What is incorrect about the condition? So let's focus on the ECG per se. The axis looks pretty normal. Lead 1 is positive, AVF is normal. Heart rate cannot be commented because this is not a contiguous strip, but then to aid you in the diagnosis, he has definitely put on an arrow. So let's just zoom in into this area. You will notice that the moment the P wave will finish, there is no Q wave present. There is a slurred upstroke present here, which is what we call as delta wave. And then you can also notice the slight prolongation of the RS complex. I did not use the word QRS complex per se because you see there is no Q wave present. The RS complex of this patient is relatively broad, and every time we have a short circuit in the heart in the form of bundle of Kent, there will always be aberrancy. Aberrancy means time taken for the current to pass into the ventricles will be relatively slow. Please appreciate that bundle of Kent itself is very fast conducting, so it will make the heart beat faster. But when in the ventricles, the current will travel relatively slow. In fact, I can just draw a line diagram to highlight this, though it has been highlighted in the main lectures also. You see the current will flow like this: SA node, AV node, bundle of S, then we'll go to left fascicle, right fascicle. This is going to be the Purkinje network, and this that I've highlighted is the cardiac muscle. Now what I'm saying is that if there is going to be a short circuit in the heart in the form of bundle of Kant, the current will definitely travel fast through this area. But when in the muscles, then it is not the Purkinje network. It's not. Purkinje is the fastest fiber in the heart. Purkinje network will not be used, and there will be a very fast conduction that will occur right to the ventricle. But inside the ventricle, it is going to be an intermyocyte conduction. Intermyocyte conduction is slower than the conduction that occurs by the Purkinje fiber. So as such, the RS complex will be relatively broad in this person. So based on this information, let's look at the options here. A says pre-excitation. Yeah, WPW is the clinical diagnosis in this case. It is a condition where ventricles are getting excited earlier than normal. Why am I saying that? Because AV node of yours and mine is very slowly conducting. AV node has a decremental property. It will put on the brakes. But this blue fiber that I've drawn is ultra fast conducting. This is gonna be like a, I would say, like a skating ring, like an ice skating ring, right? Minimal friction. So the current is just going to zip across, reach into the ventricular muscles and cause a early firing of the ventricles. And why early firing of ventricles is bad is because you see ventricles per se, they should get time to get filled with blood, then they should contract. If you are going to activate the ventricles early, it is not advantageous, it is disadvantageous. Why? Primarily because the ventricles did not get sufficient time to contract. There is a wide RS complex, it's written QRS complex, that's okay by us. Delta wave is anyway what I've highlighted, the aberrancy that is present. And especially for this particular condition, whenever you will see or whenever I have a hand on this, I've said the moment the P will finish, that is when this will be a slurred upstroke like this. This is how I have highlighted, and the same thing is being reflected here as well. Especially in lead V5, you can also see even in V6, the same kind of configuration can be seen. So that's the delta wave for you. Even in lead V3 is visible. D says pacemaker is the treatment of choice. Guys, pacemaker is useful for treatment of bradyarrhythmias. In this condition, I need to burn the abnormal pathway. The treatment of choice for a person having Wolff-Parkinson-White syndrome is radio frequency ablation. Though we have drug support also, we can be using flecainide, we can be using, flecainide is obviously the preferred drug. We can use procainamide in emergency situations, but the main treatment of this person is not drugs, because the day he will forget to take the drug, again the episode of palpitation, syncopal attacks will occur. The correct answer to this question is option number D. Please remember, we do not use a ICD here. ICD is used for tachyarrhythmias. We do not use a pacer or a pacemaker in this case. Why? Because pacemaker per se, that's gonna be primarily because of it's gonna be used wherever the conduction defects are slow, or whenever I use the word heart blocks per se. This patient is having aberrant conduction. That is, there are two circuits in the heart, the normal one and the abnormal one, and the current is preferentially going by the abnormal circuit. That's what we want to burn, and therefore there would be relief in the symptoms of the patient. The next question talks about a 25-year-old female. She had a very strong coffee and then she's having these palpitations. Her ECG is given below. What is the first line of management? Well, whenever you study about sympathomimetic stimulation and then complaints of palpitations, we have to think in terms of usually a supraventricular tachycardia. Now, if I just zoom in into the ECG here, you will notice that the RR interval of this patient is approximately about 1.5 large squares, give and take a few I would say. So average heart rate of this person will turn out to be approximately 200 beats per minute. And then you will also notice that you cannot make out the T and the P wave separately. What you can make out is, and I'll zoom in further, you definitely can make out this narrow QRS complex in a sense that R and S are literally jumping on each other. Now I'm doing an ink change and highlighting that there is some magnitude of ST depression. In fact, I'll just make it a little more prominent for you. You will notice that there is some magnitude of ST segment depression. And then in color blue, I am showing a wave which is formed due to merging of the P and the T wave. The P wave of the next complex and T of the previous one. This is what I'm saying, guys. Let me say this is PQRST, normal sinus rhythm. Again, I'm going to show PQRST. In patients who are having a supraventricular tachycardia, which is called as PSVT or AVNRT, these R and the R waves will come closer to each other. When R and R will come closer, then the T of the first complex and the P of the first will also come closer. Because they will come closer, they will merge. So ultimately, the ECG of this patient will shape up like this, a very narrow QRS complex. Then there's a single wave. I'll just highlight that once again. You will be able to notice some magnitude of ST segment depression. I've just highlighted that or exaggerated that ST segment depression. In some ECGs, it may not be so prevalent, or I would say so prominent. Why? Because of the heart rate which is increased. So this is the kind of representation that you will always get for paroxysmal supraventricular tachycardia, also called as AVNRT, and that's very characteristic ECG that is regularly being given in the exams. In fact, ventricular tachycardia and PSVT are something that should never ever be missed. They're very simple and straightforward, and for any person who's having a PSVT, we shall be using carotid sinus massage, then adenosine, and then if required a DC shock, especially if the BP is low. Here the question is saying that what is the first line of management? So answer is carotid sinus massage. If it is not given in options, the correct answer would be IV adenosine for this case. Amiodarone is ruled out because it is useful for treatment of ventricular tachycardia. If in this MCQ unrecordable BP was given, if we will always talk about a tachyarrhythmia and talks about hemodynamic compromise, he talks about unrecordable BP. That is where cardioversion is done. And PCI is anyway ruled out because that is done for management of patients of ST elevation MI, and this person is rather having a paroxysmal supraventricular tachycardia. Considering the young age of the patient, the sympathomimetic stimulation, the ECG record on narrow complex tachycardia, the final conclusive diagnosis of the patient is PSVT. Adenosine should be used in this case. The next question talks about a 60-year-old patient who was thrombolized post-ST elevation MI, and the ECG is showing these broad QRS complexes, which we can call as premature ventricular contractions. Because all you are seeing is ventricles contracting again and again and again. So the first impression is, if you are having multiple premature ventricular contractions, it could be a VT, a ventricular tachycardia. Let me just zoom in for the heart rate of this person. You can definitely notice 3 large squares. In fact, it is more than 3 large squares. So one thing is very sure, that in this case, in spite of premature ventricular contractions, the person is not having a tachyarrhythmia. Rather, it is a normal heart rate. So this is definitely not a VT. Now let me consider the options. If I look at Wenckebach phenomenon, it will always be associated with bradycardia. In fact, Wenckebach phenomenon will always be having a serial prolongation of PR interval. In this case, you can't even see the P waves present, so there is no point of PR interval. And more importantly, Wenckebach phenomenon should be having a bradycardia, whereas in this case, the heart rate is at least normal, or let me say in the upper limit of normal. Mobert's 2 heart block is again a bradyarrhythmia. Heart rate should have been less than 60. So two options can be ruled out simply on the basis of fact that in Mobert's 2 heart block, the PR interval remains normal, but then you will be having dropped beats in both of them. Dropped beats basically means that there should be a P wave followed by an absent QRS complex. So both the C and D are unlikely as answers to this question. Between A and B, well, ventricular bigeminy. It will appear like this and has been discussed in the earlier part of discussion also. You will be able to see normal sinus rhythm. Then you will be getting is this huge broad QRS complex. Then again, alternatively, there will be a normal sinus rhythm coming up in the patient. Name ventricular bigeminy is called so because you have alternative premature ventricular contractions and then is going to be normal sinus rhythm. This ECG is not having any NSR present. In fact, I'll just highlight the names here. This is NSR, normal sinus rhythm. And the green that I've highlighted is the premature ventricular contractions because this is going to be alternatively present. We call it a ventricular bigeminy. In this case has been ruled out since this is ECG definitely not looking like this. This is, guys, what is called a slow VT. Slow VT is accelerated idioventricular rhythm. This is usually encountered post thrombolysis. The correct answer for this question is option number A. I want to highlight that this is rather a very harmless reperfusion arrhythmia. You see, if a person is having blockage in any one of the coronary artery, the moment you will do thrombolysis, once you open the coronary artery, there would be reperfusion. So in earlier times when we were not having PCI facility, rather they were using this as an indicator because this used to resolve in a couple of seconds or minutes. This reperfusion arrhythmia is what is called as accelerated idioventricular rhythm. It is a harmless condition. Why? Because heart rate is normal. See, the problem with any rhythm disorder is when the heart will beat very fast or very slow. That is when the cardiac output will begin to fall. In this case, the blood pressure will rather remain normal. It is just a finding that comes once the coronary artery gets opened and then it resolves on its own. It does not require any treatment. The name is accelerated idioventricular tachycardia. It is called as slow VT. That does not mean heart rate is less than 60. It is just a word or English way of teaching you that ventricular tachycardia will obviously be having a heart rate more than 100. Here we calling it slow on a relative term that the heart rate will be less than 100. So this ECG shows multiple premature ventricular contractions. Had in this ECG the heart rate of the patient being more than 100, your diagnosis would have been VT. Monomorphic if the size of all of these was equal. If this size was also varying, then you would have called it a polymorphic ventricular tachycardia. So in this question, I've taught you three aspects related to PVC sequences. One can be ventricular bigeminy, other can be slow VT, another can be ventricular tachycardia. Broad complex and narrow complex tachycardia is always asked in any entrance exam. Whether you want to sit for USMLE, you want to sit for PLAB, or whether you sit for any routine PG entrance exam in India, or any I mean your screening exam, etc. You'll always notice questions coming on narrow complex and wide complex. So this exercise should definitely be a benefit to you. The next question talks about a marathon runner who's developing occasional missed beats. Now the moment you read about missed beats, the first thought process of yours will be that this would either be Mobert's 1 or Mobert's 2 heart block, because that is where there's gonna be a problem either in the AV node or in the bundle of his, and that is where the missed beats will come. So let us just analyze the ECG. If you scan through the ECG, what you will notice is you definitely can notice a P wave. After a P wave, there should be a QRS, like you can notice before previously occurring. If I just point to the previously occurring P waves, after every P there is definitely a QRS coming, but now after P there is no QRS. So this vertical arrow has just been put to highlight that there is a missed beat. I mean, this person was saying that I was feeling dizzy, and if I put my hand on my pulse, I feel as if the pulse is in between disappearing. So missed beats always point towards etiology being either Mobert's 1 or Mobert's 2 heart block. Let us now see what are you supposed to do. In the exam, because there is limited time, whenever you read about missed beats, just identify the missed beat, then look at the PR interval after, and then look at the PR interval before. You are noticing in this case a gross disparity. The PR interval after and before, you can notice, is not same. Rather, the PR interval before and after is unequal. And since you read this information that PR interval before and after is unequal, as a result of it, this would be diagnosed as Mobert's 1 heart block. In Mobit's 2 heart block, whose ECG I will also show you subsequently, the PR interval before and after is gonna be equal. And now let me just highlight on what they teach you in routine medical college as well. Just look at the PR interval the first time. Compare that with the PR interval the second time, and then compare it for the third time. If I just put alphabet A, that's for the first PR interval, B and C, you can notice a serial prolongation of the PR interval of the patient. There's a missed beat, and then the pattern is getting repeated again. Again, there is a serial prolongation of the PR interval of the patient. So the highlight of Mobit's 1 heart block per se is that there is a serial prolongation. Why? Because the problem lies in the AV node. The AV node is anyway slowly conducting. It is ultra slow conducting in this case, to the level, I mean, it is so lazy, so slowly conducting that sometimes the P wave may not be conducted to the bundle of his, and if there's no septal activation, no contraction of the ventricles for a fraction of a second, no blood supply to brain, that is responsible for disease spells. Mobit's 1 heart block, guys, can be physiological or it can be pathological. It can be physiologically present in marathon runners due to high vagal tone. The correct answer for this question is Wenckebach phenomenon. Mobit's 2 heart block, how do they rule it out? The point is PR interval before and after should be equal. Whereas in this case, you will notice, I'll just highlight this, the PR interval before and after, the comparison PR interval has to be done. First, you will always look at after, and then you will always look at before. This is the PR interval that I am talking about. The comparison is clearly showing a disparity in the duration of the squares. So that is why this is Mobit's 1. If it is equal, it is Mobit's 2. Complete heart block is always going to be having a AV dissociation, which basically implies that the atria and ventricles are going to fire at a slightly different rate. In fact, when it comes to complete heart block, the number of P waves and number of RQRS complexes or R waves is not going to be equal. In complete heart block, atria fires at 100, ventricles fires at 40. Atrial firing rate is 2.5 times higher than the firing of the ventricle. So number of P waves will be more than the number of the R waves. Whereas in this ECG, you can notice that if for every P, almost there is a QRS complex present, then yes, I agree. There is one P which is going to be followed by a missed beat. But if you notice gross disparity in the number of P's, like almost P waves are 2.5 times more than the number of R, and there's a broad QRS. The word is broad QRS, then it is complete heart block. Well, sinus bradycardia is anyway ruled out because sinus bradycardia would be having no variation in the duration of the PR interval. PR interval will be prolonged, no doubt about it, but at least it will not show a serial prolongation. So as I've highlighted, the serial prolongation is Mobit's 1 heart block, also called as Wenckebach. We move to 14. Canon A waves are encountered in JVP of a patient, the ECG shows. In this ECG, you can notice P wave, then you can notice a ultra long prolonged PR interval. You can again notice a P wave present. You can notice a substantial increase in the PR interval of the patient. Then again a P wave. There's a missed beat now coming up. I mean, there's no QRS complex. Again a P wave. So just count the number of P's here. I mean, if I just put pointers here for the number of P waves present, you will notice that the number of P waves that are present is more than the number of the R waves present. I mean, if you count, there are 5 P waves and there are 3 QRS complexes. So there has to be some problem with coordination. Let's just calculate the atrial rate. How do you calculate the atrial rate, guys? Atrial rate is calculated by calculating the distance between the P and the P waves. So I'm going to just use a different color for contrast sake. I'm going to count the number of squares which are going to be present between the P and the P waves. And then what I'm also going to do in the ECG of this patient is I'm going to count the number of squares between the R and the R. If you just look at it, even don't you physically count it, you will notice the fact that this particular is relatively much more. Atrial rate is always calculated by counting the PP interval. Ventricular rate is counted by counting the RR interval, and that is where the problem is. In a normal person, the PP interval and the RR interval should be equal, but in this case the PP and the RR interval is unequal. Over and above this, you can also notice the number of P waves. The word is exact number of P waves is not matching with the number of the R waves. The third feature that you're noticing is that there is relatively a broad RS complex present in this patient. This broad RS complex is because it is bundle of phase which is going to be controlling the ventricles. This, guys, is a feature of complete heart block. You can solve this question even without ECG because Canon A waves are found in limited situations only. Canon A waves, where do we read them? Canon A waves can be regularly present with respect to paroxysmal supraventricular tachycardia, which we call as frog sign, or we can be having them irregularly present. Irregular Canon waves are encountered with respect to a bradyarrhythmia, that is complete heart block, and it's going to be encountered with the tachyarrhythmia, that is ventricular tachycardia. Now, how did I solve this question? You will notice that in PSVT there should be a narrow complex QRS. In this case, there is no narrow complex QRS, so I am ruling out PSVT from the options. When it comes to VT, heart rate should again be more. So tachycardias can be straight away ruled out as causes of Canon A waves in this ECG. This ECG is definitely having a bradyarrhythmia. I mean, just count. Let's just do this activity. In fact, if you count the number of large squares, it's going to be approximately 8 large squares between the R and the R waves. So just look at the heart rate, guys. It's going to be less than 40. I mean, I would say it would be something in the range of 35, 36 only. So that's extremely slow heart rate. You see, there are 3 important causes for Canon A waves that you need to know: PSVT, VT, and complete heart block. If you can rule out the 2, you are still having the diagnosis. In this case, complete heart block is also called as 3rd degree heart block. Second degree heart block has 2 varieties, Movitz 1 and Movitz 2. I've also told you the hack how to crack it. Look at the missed bit before and after. If it is equal, it's going to be Movitz 2. If the PR interval before and after is unequal, as I showed you in this particular ECG, I'll just zoom it in once again for your convenience. Look at the PR interval wherever written C, and then go and look at the PR interval. This one I'm pointing out. Look at the PR interval, the one that was just highlighted, compare with the one that is before, and you can notice a marked disparity in the duration of PR interval. So that's how you crack Movitz 1 basically. Answer to this particular question is option number C. And I just wanted to remember that a lot of questions of cardiology, ECG will always be given as a distraction to you. It is just being aware of the theory which can be actually beneficial and can help you solve the question. The next question talks about a patient who has developed missed beats after thrombolysis for myocardial infarction, and the ECG is showing definitely an increase in the RR interval here. Let's just look at the RR interval, 6, 7, almost going up to 8 again. So if I divide 300 by approximately 7, again you can see heart rate would be something in the range of 40 only, which is dramatically problematic. Now I'll follow what I just taught you. I will look at this P wave, and after that I'm putting a vertical arrow to say that there is no QRS complex. So that is where the missed beat was actually present. This is the area of the missed beat. Now you will be counting the PR interval after the missed beat and PR interval before the missed beat. I'll zoom it in for your convenience. The size looks almost the same because the PR interval before and after is of equal duration. This means that this person is having a Movitz 2 heart block, and Movitz 2 heart block after MI can even cause sudden cardiac death. I have taught you the fact that one of the important causes of sudden cardiac death after myocardial infarction is ventricular fibrillation. That's a tachyarrhythmia. But if he asks you which bradyarrhythmia can cause sudden cardiac death after myocardial infarction, it is going to be Movitz 2 heart block. You can give atropine, but you will subsequently require TCP, transcutaneous pacing, for this particular patient, even a transvenous pacing. In fact, you can go through the MCQ of symptomatic bradycardia with a pulse, or rather you can go through the lecture also of symptomatic bradycardia with pulse, where I've highlighted regarding these bradyarrhythmias again. And I also want to tell you a AHA update that currently the dose of atropine has been changed. In earlier guidelines, the dose of atropine given was 0.5 milligram, but in the current protocol, the dose of atropine is 1 milligram. Maximum dose is same. Maximum dose of atropine that you can give is 3 milligram, but earlier it was 0.5 milligram into 6 shots. That was up to a max of 3. But now he's saying that you don't need to. I mean, I would say give repeated shots of 0.5 milligram. Again, he says give 3 shots of 1 milligram, 1 milligram, 1 milligram, and most of the time after giving 1 shot only, you will come to know whether he's responding or not. Because if the heart rate remains almost the same or slightly increases, I am knowing that okay, I'm on safe ground. But suppose heart rate is 40 or going on to 35, 30, and I give atropine and still it is 30 or it is going less than 30, I need to immediately switch on to TCP, that is transcutaneous pacing, and I've explained how TCP is done in the symptomatic bradycardia and pulse follow discussion. The answer to this question is beta. A class 12 student collapsed suddenly during a physical exercise, died on the field. Postmortem specimen is shown, and there's a family history of heart disease. Very characteristic question. Everybody can very easily pick up the septal hypertrophy. You can also see the free wall thickness present. So the clinical diagnosis of this patient can be made up right from the specimen itself. Hypertrophic obstructive cardiomyopathy. The question is saying which intervention would have prevented this from happening. So for hypertrophic obstructive cardiomyopathy, we need to deploy a implantable cardioverter defibrillator. If this device was deployed in this patient, it would have delivered a DC shock and terminated the tachyarrhythmias present in this case. Most of the time, the tachyarrhythmia which will contribute to this person collapsing suddenly is either ventricular fibrillation or it could be PVT, that is pulseless ventricular tachycardia. In patients who are having this excessive increased in the cardiac muscle, the oxygen demand is tremendous. And while he collapsed, he collapsed during physical exercise, like it could be a PT period, no? The PT teacher was making children do some exercise, some stretching exercises maybe, because in class 12 there's already so much of load of studying that the PT teacher decided, okay, to all the boys, okay, do some running, like you've been in the school, right? I mean, you know how PT teachers are, and the moment they spot boys, they say, okay, do running, do 2 laps of the entire school field. Now, if a guy is fit, he can do it. But in a guy with HOCM, if you make him stress out his heart, he can not only develop syncopal episode, but he can actually die as well. And those are the important arrhythmias that can happen. We can prevent this from happening by putting up ICD, implantable cardioverter defibrillator. Coming to the next question, he's talking about a 22-year-old footballer who has died suddenly while playing. His ECG was done in a pre-tournament health camp, and probably some findings would have been missed only. Now, what is the ECG finding that was missed in this guy, resulting in sudden death? So if I zoom into the ECG, you will notice that there is relatively a broad QRS complex coming up in this guy, and then you can notice a very peculiar wave present with a T wave inversion. In fact, what I can say is that this guy was definitely having a very significant left ventricular hypertrophy, and because of this hypertrophy, there was strain on the heart, and therefore T-wave inversion can be encountered in patients who are having a significant increase in oxygen consumption of the heart. So one thought process of mine is he could have died because he was having an athlete's heart. You see, when athletes, like we take up case of Ronaldo, Messi, or anybody else, these guys train very hard from a very young age, so they can definitely develop hypertrophy of the heart, and hypertrophy of the heart is good in a sense that they can definitely be able to perform better. The type of hypertrophy that we usually see in athletes is eccentric hypertrophy of the heart. So that increases cardiac output, that causes them to generate more power. But at the same time, if a person is having T-wave inversion, he should have actually retired from professional football, and the abnormal wave that is put in the red arrow is what is called as epsilon wave. Guys, this guy was having rather arrhythmogenic right ventricular dysplasia, which is a subtype of dilated cardiomyopathy, and this again can contribute to sudden cardiac death. As the name itself is self-explanatory, arrhythmogenic right ventricular dysplasia, this can have fibrofatty deposition in the right ventricle. The answer to this question is A, then this guy actually should not have been a football player in the very first place. In fact, this abnormal wave that is present in the patient after a relatively broad QRS complex is what I have highlighted as an epsilon wave. If I was talking about a patient of bradycardia following hypothermia, then at this juncture where I put the vertical arrow, the wave that would have been coming would be J wave. J wave is present in the setting of hypothermia. So I can definitely rule out Osborne wave in this case. That's the Osborne wave, also called as J wave. For diagnosis of option number C, there should always be a setting of hypothermia where the core temperature of the body is less than 35 degrees Celsius. But as such, there is no hypothermia setting in this case. Delta wave is always seen in the upswing of the R wave. I mean, when I drew the delta before you, the moment the P is finishing, this is where the delta wave was starting. So there's no abnormality in the starting of the R wave, rather the problem is occurring at this juncture. This is P, then is QRS complex. Where the QRS complex is ending, that is the area called as the J point, and exactly at where the J point is present is this abnormal looking wave, which is called as epsilon. T-wave alterance means T-wave height increasing or decreasing in amplitude. That can again be an aberrancy in the ECG of some people and can predispose to tachyarrhythmias. The correct answer to this question is option number A. Coming to the next question, he talks about a short stature female presenting with history of wearing socks in the summer season. Physical examination is showing icy cold toes with cyanosis. Now that's definitely a cause of concern. Cyanosis in the toes of the patient. This definitely means that either this person is having peripheral cyanosis, or could be having a differential cyanosis. Now, when you focus on the X-ray of the patient, the arrows are basically signifying, and I'll just zoom it in for you. There definitely appears to be some damage in the lower part of the ribs. The radiological finding which has been shown here would be referred as inferior notching of the ribs, and this is what you always encounter with coarctation of aorta. You see, the problem is in coarctation of aorta, there is formation of collaterals, and the collaterals that are going to be formed here is intercostal arteries. These intercostal arteries become dilated and tortuous, and now you can see the way I'm sketching the intercostal artery just below the rib, and when this artery will pulsate, the pulsations of the artery can actually cause these erosions to be present, which is called as or referred to as inferior notching of the ribs. The message is coarctation of aorta patients, because there is less blood supply going to the toes of the patient, so there can be a differential cyanosis. The usual site of coarctation of aorta happens to be the descending aorta of the patient. So because less blood will go down, that is why the toes of the patient will be relatively blue, as contrast to the lower limbs. The upper limb of the patient will be receiving blood supply directly from the arch of the aorta, so therefore I would say the fingertips of this patient will remain totally pink. Another information that can be given in the question for coarctation of aorta can be disparity between the blood pressure values of the patient. So the correct answer for this question is option number C. How did I rule out option A? Well, straightforward. There is no evidence of hypercalcemia. There is no kidney stones present. There is no calcification of basal ganglia. So obviously A is out of the window. Neurofibromatosis to be diagnosed will require diagnostic criteria like I would say Lisch nodules or presence of axillary freckling. There can be obviously lesions present on the skin. So as such, there is no potato tumors developing here. Neurofibromatosis will be a tumor originating from the nerve per se. So person should be having these palpable nodules which will be firm in consistency, mobile only along the direction of the nerve. Option number D, multiple myeloma will be present in old people, and the clinical features of CRAB, hypercalcemia, renal failure, anemia, bonilytic lesions should be present. So I think if you try to solve this question by exclusion, still the answer can easily be worked out. The combination of short stature female is pointing towards actually Turner syndrome, because you know Turner is associated with the coarctation of aorta. So he began by describing a Turner syndrome patient who's made fun of by his or her friends. Why? Because person is wearing socks in summer season. It's a little hot in India, sweaty, right? So to wearing socks in summer season is not something which most of us would be very comfortable with, unless and until you are wearing, you know, a proper pair of shoes. Now, physical examination is showing this characteristic cold toes with cyanosis. That indicates less blood supply, and the person is not in shock. No, I'm not saying that a person came with excessive bleeding and there are icy cold clammy hands and feet. Then it's a different thing. Then it would have been peripheral cyanosis occurring in a patient. But in this case, due to a reduction in blood supply downstream, that is why there's a peripheral cyanosis of the differential variety in these patients. Answer is C after the justification I provided. Coming to the next question, he's talking about chest x-ray of a 15-year-old boy with a low cardiac output. What is wrong about the patient? If you look at the x-ray, one of the very characteristic features that you will notice here will be straightening of the left heart border. I mean, normal cardiac border is obviously not going to appear like this. We always have an aortic knuckle, then you have a slight concavity, then you have his left atrial appendage, and then you have his the left ventricle. I mean, this is how the normal cardiac left-sided border should be appearing. But in this particular case, what is happening is rather that there is a fullness in the pulmonary artery segment. There is definitely fullness in the left atrial appendage area segment also. I'll highlight this once again, guys. What I am saying is that after aortic knuckle, in you and me, there should be concavity present. But look at the fullness which is present in this case. That indicates pulmonary artery hypertension occurring. And why does pulmonary artery hypertension occur in a boy? Then it could be a valvular lesion. One of the common valvular lesion which is associated with rheumatic is gonna cause straightening of the left heart border. The main keyword in the MCQs too, one is the age of the patient and second is the radiological finding. If it's a boy with straightening of the left heart border, the first thing that I will think here will be presence of mitral stenosis. And well, if I look at option number A, reverse split S1. In mitral stenosis, the problem is the orifice will become relatively more narrow. So blood will take more time to go across this narrow area. So mitral valve will close late. In fact, it might close so late that mitral and tricuspid valve might close at the same time. So I'm going to call it single. And if it's a progressive lesion, if the opening will become more narrow, then there could be a possibility that mitral valve will close after the tricuspid valve. That is what is written in option number 1, reverse splitting of first heart sound. So this is correct. Straightening a left heart border, I could pick it up. Caricomb's murmur is the etiology behind mitral stenosis. You very well know that rheumatic heart disease is the main reason behind Caricomb's murmur. Seagull murmur, which is the answer to this question, is a feature that you see with aortic regurgitation. For seagull murmur, I've explained like this: like if an ambulance is coming towards you, the noise of the siren of the ambulance will become much more louder to you. But as the ambulance will go away from you, it passes by you, then the sound will fade away. Similarly, if we talk about a bird, like bird in the sea, seagull, right? If it flies over you, when it's flying over you, you can hear the loud chirping of the or loud noise produced by the bird. But as the bird will flow away, the intensity of the noise will decrease. You see, aortic regurgitation has a decremental murmur. What I mean by decremental is that if you're going to auscultate aortic regurgitation patient of mild to moderate variety, the murmur intensity will reduce right in the early part of diastole. The murmur of aortic regurgitation is called as early diastolic murmur, and it has a decremental property. So as the sound decreases, that is what I'm saying, the bird going away from you, the sound decreases. That is what is the nomenclature here. Seagull murmur is seen in aortic regurgitation, whereas what we are discussing in this case is a case of mitral stenosis. So these are a couple of questions from cardiology domain that I want you to be thorough with, and keep learning guys, keep hammering, and you will come out with brilliant colors in future.